I am just thank you for organizing Balu and surgical gastro team, and thank you for accuracy giving opportunity to talk on the topic. Fistula, I am talking about the Rojanasakul patterns and mapping for better fistula understanding. When it comes to fistula, one MRI report, for a surgeon it will become, we will go through the report, at the end of the day, we will conclude that lot of thing has been written and we can't interpret. At the end our conclusion is it is a complex fistula. And when surgeon think complex fistula, whole vicious cycle runs, I need to do less or I need to do more. At the end of the day, recurrence is acceptable, incontinence is not. We will do less and lot of time recurrence is the problem. For that purpose, Dr. Rojanasakul has introduced the patterns and mapping about the fistula to understand how to interpret that fistula. I am just quoting this. So I bring greeting from Symbiosis University Hospital, Pune. I am here a consultant. So disclaimer, this is a presentation, all the concept belong to Dr. Rojanasakul, nothing of mine I am delivering here. And many of the animation and slide I have prepared, with his permission I am presenting. So let's go for the purpose of any classification of the fistula. If it comes classification, that has to define at least three things for us. The simplify and standardize communication between the clinician. So some classification is there. If we tell it is acute gallbladder or simple gallbladder, something we can interpret from that thought of the radiologist or next surgeon who is sending to me. Second is, that should guideline the surgeon to appreciate about the complexity, and also appropriate treatment option has to guide. So coming to third question, it is more important that at the end of something we classify the fistula, surgeon should be at the stage to tell prognosis to the patient and think about the complication. If at all we are telling simple appendix or perforated appendix, I will tell the patient that I am going to do the open surgery for complicated or abscess. I will tell the patient that it is a complicated patient, I need post-op longer recovery, I need open surgery. Something should come in the fistula. So everything is crumpled up, because of that we get a lot of confusion. For that reason, we need to first understand what is available classification as a surgeon, as a radiologist we are following. This is a one famous classification, and I think this is the first intent has been done in fistula history by the Park to give the Park classification. It's a wonderful classification and it is a commendable job done at that time around 35-40 years back. He has given 4 types. In fact, it has been sub-classified and given as a 14 type. Lot of thing has been put on the picture, on the book. In fact, we are all following this. Let's go into the minor details of it. It is a surgical classification based on physical examination, because MRI was not that available in that era. And it's a most easy, most simple, and most easily can tell that is it a transpintric, it is a interspintric or supraspintric fistula. And it is based on only coronal plane. Axial plane are more important, has been not considered because it is a pre-MRI era where this classification has been proposed. Now coming back, should it be used in this present era, this classification? That's the question. It is a pre-MRI area, and at present whatever we do fistula, it comes a complex fistula. In fact, few of the studies are going in favor that even it's simple fistula, do the MRI, because lot of fistula, 30% will get converted into the complex when you do the MRI. And more important is, not doing MRI, we are not justifying the patient in every case. It's not that every case should be done, it's not bold statement, but doing MRI, our understanding will improve. At the same time, we may be better with seeing. If we see 100 of CT, my diagnosis on the CT image will improve. Doing MRI, that will also going to improve. So if we see these patterns, what is happening is a mixed fistula in every class, because interspintric high is different, low is different. Transpintric low is what sir has told, very good. Low we can do blindly fistulotomy, but high we can't do. That everything has been mixed and put in front. If we see this interspintric means both are there, high interspintric, low interspintric. Treatment for both is absolutely different, but has been clubbed and put in type 1. If it is coming to transpintric, low transpintric, high transpintric, treatment for both is different, but has put in one. But at the end of the day, if you tell transpintric, I cannot conclude what to be done. That is the problem. Data is skewed. If you see, more fistula has been classified in a first 2 types and less in the last 2 types. So data has been skewed towards the simple and has been mentioned lot. So third thing is coming is extraspintric, supraspintric. As per the many of the legends who has been doing work in the fistula is, these type may or may not exist, and many of the papers are there, they couldn't find. In fact, if we see Park's only paper, starting from the Park classification, over the period of 3 or 4 big paper what has been published, the extrasphincteric suprasphincteric portion was reducing. And in fact, one of the Eisenberg paper also is mentioning that it may be erroneous or it may be iatrogenic. It cannot be a classical cryptoglandular fistula. Coming to the thing, St. James, basically this is 1992, I think, I may be wrong, that has been done by St. James University classification. This is also belongs to the Parkes University only, where Parkes classification has been done. It is nothing but just replication on MRI, based on the MRI, same classification. What has been done is, it is MRI based, mostly used by radiologists. Even this classification comes, it doesn't give a conclusion for the surgeon what to be done for this case. So it is more or less like a Parkes classification, doesn't have much in surgical planning. If you see intersphincteric abscess, it is intersphincteric fistula only, they have given 2. Transsphincteric abscess, it is a type 2, it has been just separated into 2 classification. And type 5 has been made as a separate. So it is also not much helping, and in fact, present true condition is we do MRI for many cases, but at the end, again we will put our thought process, Goodsall-Ra and our surgical inception and do the case. So coming to what Arun Rojanasakul quotes is, this is very important quote, what he quotes is, if it is a classical cryptoglandular origin fistula, he tells as anal sepsis. To demystify fistula and abscess, there is many of the time we see that it is a fistula having a abscess, and many of the time it is an abscess which is having the fistula. It's not too different, rather than he call it as a anogenital or anal sepsis. Anal sepsis is predictable. It always spread between the muscle and spaces, and anal anatomy and pattern is constant. We need to understand, means we need to understand that. So coming to that, what he tells is, to understand the anal anatomy, particularly for the fistula, we need to understand 3 things. That is, one is anogenital muscle, second is anogenital spaces, third one is anogenital fascias. That sir has also given a complete overview. Just we will focus more about what is surgeon's fear. It's not an internal sphincter. Internal sphincter we can divide, but the external sphincter, how and where we need to divide, that we need to clarify. And every time fistula we see, we need to focus on that part only. So coming to that, he has given the 3-level concept of anogenital striated muscle, where upper level, middle level and lower level. If we see lower level is counterpart to bulbocavernosus, which is a subcutaneous external sphincter, which blindly you can cut. It is a 8 mm to 1 mm and nothing going to be incontinence. Second level will come is anococcygeal ligament to superficial sphincter, and that is superficial external sphincter, which is separated by the perineum by the superficial transverse perineal muscle. This is caution. Every case cannot be divided. If it is anterior fistula in female, it become a complex fistula where you should not divide it, where it apply the sphincter preserving procedure. If it is coming the Crohn's patient, we should not divide. If it is coming recurrent prior fistula surgery done, having the sphincter weakness, you should not divide. This land into the incontinence, should be cautious. And coming to third, levator ani, deep part of external sphincter and levator muscle clubbed together, he call upper level as a levator ani. This at any cost we should not divide. That should be the principle. So he has demonstrated over the hundreds of cadaver. That cadaveric image, levator is, upper part is levator, middle is superficial external sphincter, and lower part is subcutaneous external sphincter. This is simply to understand what is relevant to the fistula. Coming to 3-level concept, that's levator is upper level, which should not be cut, and middle level superficial external sphincter, which can be cut in few cases, should not be cut in few cases, that we need to understand. Last is you can cut without any fear, that is a subcutaneous external sphincter. Coming to next concept about the perianum is anal fascia. Anal fascia is also very important to understand the pattern. If it is coming to anal fascia, there is something called intersphincteric fascia, we all know. There is a fascia in the intersphincteric space. And second, sir has mentioned that Milligan's fascia or transversalis fascia, which goes across and divides the lateral part into 2, and above another one is infralevator and ischioanal, which divides by the ischioanal fossa fascia. There is 3 fascia which we need to understand. Coming to that, it will divide the perineum. If we see, this is the part of ischioanal fossa fascia and transverse fascia, which divides lateral part below the levator is infralevator space, that is below the levator, above the ischianal fossa fascia. Between the transverse septum and ischianal fossa fascia, he called ischianal space, and below the transverse septum fascia, he called perineal space. What he suggests is, when we call ischiorectal, again surgeon get confused about rectum and other thing. So simply he avoids using the quote of ischiorectal, he always talk about the ischianal space. Coming to next is, there is a spaces. When we understand the muscle and fascia, it is very easy to understand the spaces. There are mainly 7 spaces which we need to take into account when we are dealing with a fistula. Those are, that is laterally above the levator is supralevator, below the levator above the ischianal fossa fascia is ischianal space, and coming down is a ischianal space, and lower is your perianal space. In between the internal sphincters is intersphincteric space. Posteriorly deep to the ischianal fossa, it is a deep postanal space. Anterior counterpart is perineum space. So if abscess is there at area, we can call it as intersphincteric abscess, perianal abscess, ischianal abscess, infralevator abscess, supralevator abscess, and deep postanal abscess. That is a perineum, anteriorly perineum abscess. So it will become easy to understand what's going on in the perineum. So this much if you understand, we can classify any of the fistula and any of the thing, and we can predict. That's what his concept is. Coming to the fistula pattern, he suggested rather than the classification type of fistula, let's understand the pattern. Understanding the pattern, what he proposes, this abscess always travel in the path of least resistance. It never crosses the muscle. That is the basic principle of any fistula. We know that how fistula form. 80% of the cryptoglandular lying medial to the internal sphincter, which will get burst and which will subcutaneous mucosal abscess, we may drain or it may get burst. If it comes to the internal sphincter goes into the spasm. Spasm of internal sphincter, then it's find out the path. There is only 3 paths where abscess can travel. Either it has to go down, it will become a low intersphincteric. Either it had to go up, it will become a high intersphincteric. Either it has to cross the sphincter, it may be low transsphincteric or high transsphincteric. That's what the pattern every fistula follows. Based on this pattern, he classifies, this is a low transsphincteric and high transsphincteric. Based on this pattern, he classifies every fistula into 5 patterns. That is, if it is coming down, it is a low intersphincteric fistula. If it is coming through the lower external sphincter, that will become a low transsphincteric fistula. Because anteriorly we have perineum, posteriorly we have deep postanal space. For that reason, transsphincteric, high transsphincteric, he classify into anterior high transsphincteric, which goes into the perineum and comes out, and posteriorly which goes into the deep postanal space and comes out, he classify it as a posterior high transsphincteric, and leftover last is high intersphincteric. So these are the 5 patterns. If we understand the pattern, we can justify our patient. And last 3 years I am using it. It can be easily, we can chop out what pattern is going on based on our experience. So let's talk on the low intersphincteric type. Low intersphincteric type, it's very easy. It is coming down. Just do the sphincter cutting procedure. There is no harm to the patient. Coming to second one, low transsphincteric pattern, which is very easy because it is going in the superficial or subcutaneous part. You can go for sphincter cutting procedure, whatever is a procedure which is preferential. But these are the most common type where fistulotomy, that is sphincter cutting, which can be done without any fear. Coming to next is anterior high transsphincteric. When it comes to a female patient, it will become a complex one. Even in the male also, if it is going in the perineum, it will become complex. Here role comes the sphincter preserving procedure. Whatever the sphincter preserving procedure of your choice, coming to lift, waft, laser, whatever is there, we can apply that. Coming to next is posterior high transsphincteric. Posterior high transsphincteric, again, this is the one of the space, one of the pattern which make more complicated for the surgeon. Routinely 80% will go to the deep postanal space, go right or left and present as a ischioanal or horseshoe tract. This is 80% what he labels. Another one, 5 to 10%, where it starts at the 6 o'clock, goes to deep postanal space, open at the pyloneedle area, which confuse with the pyloneedle opening. And last one is, which make a more problem is, it goes in intersphincteric and comes out as a short tack, it is a less than 5%. So posterior high transsphincteric fistula we need to understand. Coming to last one is high intersphincteric type. That is, he label as a intraanal fistulotomy, transanal fistulotomy. Just understand where it is going to be. And another thing what he club is, when we do procedure repeatedly, there is possible that we may have combined pattern. Combined pattern, most complicated pattern is combining with the high posterior transsphincteric with high intersphincteric. It is the most complicated pattern where we need to worry for the patient to treat. So this will be high post transsphincteric and high intersphincteric. Combined pattern will be the most complicated. So coming to a mapping, to understand the mapping, MRI, how we need to ask the radiologist, give me a pattern, give me a map. It will become more easy over the period of time. What is the problem with radiologist? He gives a Saint mask classification, surgeon read his finger, and at the end it is a weak link. What surgeon want, radiologist doesn't give. What radiologist give, surgeon doesn't understand. At the end, we are not accepting his MRI report and we are doing whatever we are continue to do better for the patient. If what has been proposed by Dr. Rojanasakul is anal fistula map. It is a template to report anal sepsis. Purpose of fistula map, document anal sepsis, where it is going, direction and associated cavity. So we need maybe in a better position to deal the fistula, we may be mapping the patient. So for mapping purpose, he gives a standard mapping format. Internal opening, where it is, we need to start, as every fistula start from inside to out, we need to start that internal opening where intersphincteric, what is available, level, it is a low intersphincteric, high intersphincteric, low transsphincteric, high transsphincteric, what spaces out of 7 we need to mention, end, is it a external opening is there or blind end is there, we need to mention, and distance, it doesn't matter, but sometime if we are planning for laser or what, distance matters. So that's what he has given. These all things we can get from the MRI. We need to ask the radiologist, these are the things we need. So if we get those all things written in the map, we can assess that internal opening where it is. We can assess intersphincteric space, is there any abscess, cavity or tract. At the levator, is it a intersphincteric, low transsphincteric, high transsphincteric or translevator. Anogenital space out of 7, which one is involved. External end, where it is ending, is it a external opening is there or blind end, we need to tell everything. So we can see that if we are pro for the lift doing, we can use a prone position, this diagram. If we are pro for the routine procedure, we can use this diagram as a lithotomy position. For example, if radiologist give this much of track, surgeon can understand. This much if he write, surgeon can understand. Let's see how the mapping works. Internal opening, IO6 at 6 o'clock, internal opening is there. Coming to intersphincteric, there is a track is there. Coming to high transsphincteric, it is going up in the high transsphincteric space. Infralevator space and ischioanal space, there is abscess. Perianal track is there and external opening at 7 o'clock. So it makes a surgeon life little bit simplifier so that we can talk in the same page with a radiologist. So take home message is understanding anatomy before any procedure is most important. It's both anal anatomy and fistula anatomy. And map your fistula based on mapping system and define your pattern based on your input from the clinical MRI based input, and then choose your procedure based on the fistula pattern. Wherever possible, do the sphincter cutting procedure. Where your sphincter at the risk, that is complex fistula, you can think, and always think about the core surgical principle, save the sphincter. Laser is a tool which we can use, added advantage, but core surgical principle should not be forgotten to treat any kind of fistula. Any question and answer, I will be happy to answer. Thank you.